Today we're going to dive into the essential topic of fluid electrolyte acid-base balance, the cornerstone of maintaining homeostasis in the human body. These systems are deeply interconnected and rely on coordinated function of nearly every organ. In a healthy individual, fluid intake and output are balanced, but when this equilibrium is disrupted, we often see combined abnormalities in fluid, electrolyte, and acid-base levels. So understanding these relationships is going to be key to effective patient care. This chapter is going to outline the principles behind these balances and explore common disturbances. You'll find sample interview questions to guide your fluid balance assessments along with physical exam techniques and relevant lab studies. We'll also discuss actual potential health problems, patient needs, and expected outcomes. Some nursing interventions are going to be ongoing assessments, adjusting diet and fluid intake, administering medications, and supporting IV therapy and blood replacement. Be sure to review the concept map that's on page 1714, and there's an evolving case study on page 1728, 41-1. Both are excellent tools to help you with clinical reasoning and judgment. As nurses, we are required to integrate our knowledge of these balances with skilled assessments and interventions to restore health and improve patient outcomes. Fluids and electrolytes are vital to life. Their balance is essential for healthy functioning of every system in the body. These elements are involved in nearly every cellular reaction and function, and the body's chemical processes rely on tightly regulated acid-base balance. Now, when we talk about body fluids, we're primarily referring to water, the most important nutrient for life. While humans can survive for days without food, we can only last a few days without water. That's how critical it is. Water plays many roles in the body. It transports nutrients to cells and removes waste, carries hormones, enzymes, and platelets in blood cells. It supports cellular metabolism and chemical reactions. It acts as a solvent for electrolytes and other substances. It helps regulate body temperature and aids in digestion, elimination, and serves as tissue lubricant. The term total body water refers to the amount of water in the body, which makes up about 50 to 60% of body weight in a healthy person. It's important that you study and understand these concepts about how fluid and electrolyte imbalances can affect health, so you as a nurse are able to intervene and restore balance and promote healing. Let's take a closer look at how body fluids are distributed within the body. These fluids are divided into two main compartments. You have your intracellular fluid, ICF, and your extracellular fluid, ECF. Intracellular fluid is found inside the cells and makes up about 70% of your total body water, or roughly 40% of the adult's body weight. Extracellular fluid, located outside the cells, accounts for the remaining 30% of total body water, or about 20% of the body weight. Now, the extracellular fluid is further divided into three key areas. Intravascular fluid, this is the plasma, the liquid part of your blood within the vascular system. The interstitial fluid, which surrounds tissue cells and includes lymph. Transcellular fluid is a smaller compartment that includes specialized fluids like cerebral, spinal, pericardial, synovial, intraocular, and pleural fluids. And it also includes sweat and digestive secretions. These compartments are separated by capillary walls and cell membranes, which regulate the movement of fluids and maintain balance. This is figure 41-1 from your textbook, and it's a visual breakdown of these components. There are variations in fluid content, meaning not everyone has the same percentage of body water. While the average is around 50 to 60% of the body weight, this can be based on age, body composition, and biologic sex. For example, infants have a much higher proportion of total body fluid, especially extracellular fluid, since ECF fluid, the extracellular fluids, are more easily lost than the intracellular fluids. Infants are at a greater risk for fluid volume deficits. Body composition also plays a role. Fat cells contain very little water, while lean tissue is water rich. So individuals with more body fat, such as those who are obese, have a lower percentage of total body water relative to their weight. Biologic sex matters too. Women typically have more body fat than men, which means they generally have less body fluids. As we age, our total body water decreases. Older adults tend to have more fat cells and less muscle mass, which further reduces their fluid percentage. After age 60, their total body water drops to about 45% of their body weight, increasing the risk of fluid imbalances in this population. Okay, so now let's look at how the body obtains water and how fluid intake is regulated. Water comes from three main sources. First, your ingested liquids, the largest source, providing about 1,500 milliliters per day. Next is water in the food that contributes around 800 milliliters daily depending on the diet. For example, foods like melons and citrus fruits are high in water, and cereals and dried fruits contain much less. And third, metabolic oxidation. The body metabolizes carbohydrates, fats, and proteins, and this produces water as a byproduct. It's about 300 milliliters a day. So altogether, your average daily fluid intake is about 2,600 milliliters. Primarily, the fluid intake is regulated by your thirst mechanism, which is controlled by the hypothalamus. This center is stimulated by intracellular dehydration and decreased blood volume, which prompts us to drink fluids to restore the balance. There's a figure 41-2 in your textbook, and I think I included on the next slide for visual representation of daily fluids in the healthy person. This is that slide. As you can see, fluid intake and losses are about equal in healthy individuals. So your fluid intake and your fluid output are in balance. We talked about how our bodies either take in water or is gained through metabolism. Now let's look how the body loses fluid and how we assess fluid balance in clinical practice. Fluid is lost through two types of process: sensible losses, which are measurable and include fluid loss through urination, defecation, and wounds, or insensible losses, which are not measurable and occur through evaporation from the skin and water vapor from the lungs during respiration. On the average daily, fluid output totals about 2,600 milliliters, broken down, as we saw on the previous slide, about 1,500 milliliters of urine from the kidneys, 600 milliliters from the skin, 400 from the lungs, and about 100 from feces via the GI tract. When assessing a patient's fluid status, we must consider both their health condition and the balance between fluid intake and output. In the healthy adult, urine output typically, again, matches the liquid intake, while water from food and metabolism balances losses from the skin, lungs, and the GI tract. This balance may not always be perfect within a single 24-hour period, but it should stabilize over 2 to 3 days. Any significant deviation from normal intake output patterns should alert nurses to potential fluid imbalances. There's a Promoting Health 4-1 display in your textbook, and it's a self-care behaviors survey. It's will help you see if your self-care behaviors are adequate. And just remember, as nurses, we model healthy behaviors ourselves, and when we do that, we're more effective educators for our patients. Okay, we talked about fluids, and we're going to talk about electrolytes. Electrolytes help regulate the body's essential functions. They're substances that break into particles called ions, which carry electrical charges. They're either cation ions, which are positively charged, and these include sodium, potassium, calcium, hydrogen, and magnesium, or anions, which are negatively charged, chloride, bicarb, and phosphate. These charged particles are required for chemical interactions in the body that support metabolism, nerve transmission, muscle function, and acid-base balance. In contrast, some molecules like urea and glucose remain intact and uncharged, and these are called non-electrolytes. The electrolyte composition varies between fluid compartments. In the extracellular fluid, major electrolytes that include sodium chloride, calcium bicarb. Again, intracellular fluid, there's the key electrolytes are potassium, phosphorus, and magnesium. We measure electrolytes in milliequivalents. 1 cation equals 1 milliequivalent of any anion. In the healthy body, the total cations and anions are balanced, and that's homeostasis. The roles of the major electrolytes include sodium, which regulates the extracellular volume. It affects osmolarity, supports nerve and muscle function. It's regulated by the renin-angiotensin-aldosterone system and the kidneys. And the normal concentration is 135 to 145 milliequivalents per liter. Potassium, it controls the intracellular fluid osmolarity and is vital for electrical impulses in nerves and muscles, especially the heart. It's regulated by aldosterone and eliminated by the kidneys. Normal serum is 3.5 to 5 milliequivalents per liter. Calcium is essential for bone and teeth and blood clotting and muscle contraction. It's regulated by the parathyroid hormone and calcitonin, and it's inversely related to phosphate. Excess calcium is excreted by the kidneys, and the normal total serum calcium level is 4.5 to 5.1 milliequivalents per liter. Magnesium supports neuromuscular function and carbohydrate protein metabolism. It's regulated by the parathyroid hormone and it's eliminated by the kidneys. Normal is 1.3 to 2.3 milliequivalents per liter. Chloride maintains osmotic pressure and helps form hydrochloric acid. It's regulated by aldosterone and closely tied to sodium and potassium levels. Usually there's only a small amount excess and available to be excreted by the kidneys. Normal serum levels are 97 to 107 milliequivalents per liter. Your bicarb, the body's primary chemical buffer. It's crucial for the acid-base balance. It's regulated by the kidneys and produced during metabolism. Normal is 25 to 29 milliequivalents per liter. So how this happens in metabolism is metabolism produces CO2, which is converted into bicarb, and when it reacts to water in the body, and it forms an acid that ultimately breaks down into hydrogen ions and bicarbonate, which is crucial for maintaining acid-base balance. Phosphate is involved in energy storage, acid-base buffering, and bone formation. It's regulated by vitamin D and parathyroid hormone, and again, it's inversely related to calcium. Excess phosphates excreted by the kidneys, and normal is 2.5 to 4.5 milligrams per deciliter. Almost every organ and body system plays a role in maintaining fluid and fluid homeostasis. So let's walk through the organs and their specific functions, which are also outlined on page table 41-2. Kidneys are the primary regulators. They control the extracellular fluid volume, osmolarity, and electrolyte levels and pH. By selectively retaining or excreting fluids and substances. They filter about 180 liters of blood daily, yet they only excrete about 1 to 2 liters of urine. The heart and the blood vessels circulate nutrients and water and help maintain pressure for kidney filtration, which increases the urinary output. When the blood volume drops, it's going to stimulate fluid retention. The lungs eliminate about 300 milliliters of water daily through respiration and play a major role in acid-base balance by regulating carbon dioxide levels. Your adrenal glands secrete aldosterone, which promotes sodium and water retention and potassium excretion. Cortisol is also a hormone secreted if it's stimulated to be secreted in large amounts, it can also affect fluid and electrolyte balance. The pituitary gland stores and releases antidiuretic hormone, which helps the body retain water. The antidiuretic hormone secretion adjusts based on osmotic pressure and blood volume, helping regulate water balance. It also regulates by decreasing aldosterone secretions, which will cause sodium and hydrogen loss and potassium retention. The thyroid gland releases thyroxine, which increases renal circulation, enhancing filtration and urinary output. The nervous system regulates thirst and fluid intake through the hypothalamus. Osmosis receptors detect changes in the extracellular fluid concentration and then signals the pituitary to address the antidiuretic hormone levels accordingly. The gastrointestinal tract absorbs water and nutrients from ingested food and fluids. And then the parathyroid glands regulate calcium and phosphate balance through the parathyroid hormone. Increase in the parathyroid hormone raises calcium and lowers phosphate, while decreased parathyroid hormone has the opposite effect. Kidneys are going to try to compensate for increased acid or base accordingly through expelling in urine. Increased urine output to excrete the excess could cause dehydration as the body tries to compensate to maintain homeostasis. Together, these systems maintain a delicate balance of fluid, electrolytes, and pH. That's essential for health. Now, how do fluids and solutes move within the body to maintain fluid and electrolyte balance? First, the cell membranes are semi-permeable. This means that the membranes allow water to pass freely, but restrict certain solutes, which are the electrolytes. This selective movement is governed by several processes. Solutes could be electrolytes or the non-electrolytes. Osmosis is one way of transporting body fluids, so it's the movement of water from an area of lower solute concentration, which means there is more water, to an area of higher solute concentration, which means there's less water, until there's equilibrium reached. This process is driven by osmotic pressure. The greater the concentration difference, the stronger the pressure. Osmosis is the primary method of fluid transport. The term osmolarity refers to the concentration of particles in a solution. Isotonic solution has the same osmolarity as plasma and stays within the intravascular space. Hypertonic solution has higher osmolarity and it pulls water out of cells, causing them to shrink. A hypotonic solution has lower osmolarity, causing water to move into cells, which may swell and burst. Why is this important for you to understand as nurses? And one reason is because we will need to intervene for patients experience fluid volume deficits with supplemental IV fluids, and we do this through various types of IV fluids, which are categorized into isotonic, hypertonic, and hypotonic solutions. And we choose the appropriate fluids to address specific issues that the patient's having with fluid electrolyte imbalances. The doctors will order it, but you need to know if you understand the rationale for why the client is going to be on a certain type of IV fluids. Another way the body fluid is transported is through diffusion, which is movement of solutes from an area of higher concentration to a lower concentration until equilibrium is reached. This applies to gases as well. Oxygen and carbon dioxide exchange in the lungs occurs by diffusion. Active transport, unlike diffusion, active transport moves substances against a concentration gradient from lower to higher concentration. This process requires energy supplied by ATP, which is adenine triphosphate, which is stored in all the cells, and it is the supplier of energy for solutes to move in and out. And this is essential for moving substances like glucose, amino acids, and ions, which were sodium, potassium, and calcium, and hydrogen. Capillary Filtration is the final movement of fluid through membrane from a high pressure to a low pressure. In capillaries, this is driven by hydrostatic pressure, which is the force of blood pushing against vessel walls. So at the arterial end, hydrostatic pressure pushes fluid into the interstitial space. At the venous end, the pressure drops and reabsorption occurs. This is the process that allows blood to circulate to the body organs through arteries and then ultimately return via veins to be reoxygenated. Reabsorption is aided by plasma proteins such as albumin, which exert colloid osmotic pressure, a pulling force that draws fluid back into the capillaries. So this balance between hydrostatic and colloid osmotic pressure ensures proper fluid exchange. So we have osmosis, diffusion, active transport, capillary filtration, and waste removal that happens throughout the body. Okay, we've looked at how fluid and electrolytes are balanced. Now let's look at acid-base balance, which is also a critical component of fluid homeostasis and overall health. The body's chemical reactions, especially those involved in metabolism, depend on a precise balance between acid and bases. This balance can be disrupted by illness, infection, or trauma, leading to serious health consequences. First, an acid is a substance that releases hydrogen ions like carbonic acid. A base or alkali is a substance that accepts or traps hydrogen ions like bicarbonate. The strength of acids and bases depends on how readily they release or accept hydrogen ions. So a strong acid and bases do so easily and weak ones do not. The next concept related to acid and base balance is the pH scale. The pH measures the concentration of hydrogen ions in a solution. The scale ranges from 1 to 14. 7 is neutral, and the example is pure water. Below 7 is acidic. Above 7 is alkaline. Normal blood pH range from 7.35 to 7.45, which is slightly alkaline. When the pH falls below 7.35, it's called acidosis. When it rises above 7.45, it's alkalosis. Both conditions can lead to illness or death if they're not corrected. This is the table 41-8 from your textbook. The body maintains pH through 3 major regulation systems. Chemical buffer system, which prevents drastic changes in the pH by either releasing or binding hydrogen ions. And there's 3 buffer systems. The carbonic acid sodium bicarbonate is the most important buffer in the extracellular fluid. It maintains a 20-to-1 ratio of bicarbonate to carbonic acid to help maintain homeostasis. The most common acid in the body is carbonic acid, and most common base in the body is bicarbonate. Phosphate buffer system is the second. It's active in intracellular fluid and renal tubules. This one only slightly alters pH. And then the protein buffer system includes plasma proteins and hemoglobin, which buffer both inside and outside the cells. Globin is the part of hemoglobin that binds or liberates hydrogen ions as needed, and it tends to minimize changes to the pH. The second regulation system is the respiratory regulation system. The lungs regulate pH by controlling carbon dioxide levels. CO2 combines with water to form carbonic acid. When CO2 levels rise, the respiratory center increases breathing rate to eliminate it, raising the pH. When CO2 is low, breathing slows to retain it, lowering the pH. This system acts quickly, but it's a short-term fix. The third regulation system is renal regulation. The kidneys are going to provide long-term regulation by excreting or retaining hydrogen ions and bicarbonate. In acidosis, kidneys excrete hydrogen and conserve bicarbonate. In alkalosis, they retain hydrogen and excrete bicarbonate. This process is slower. It takes up to 3 days, but it's essential for sustaining your pH balance. There's a few developmental considerations related to regulating your acid-base balance. Newborns are not able to acidify urine as well as adults, meaning they can excrete the acid through their urine as well. Older adults may have reduced lung and kidney function, making acid-base regulation less efficient, especially with underlying conditions. Okay, let's talk about imbalances. First is fluid imbalances, which occur when the body compensatory mechanisms can no longer maintain homeostasis. These imbalances can involve either the volume or distribution of water and electrolytes. Fluid volume deficit or hypovolemia happens when the fluid loss exceeds intake, leading to loss of both water and solutes from the extracellular fluid. To compensate, fluid shifts from the interstitial spaces, which are spaces between the cells and the blood vessels, into intravascular space to increase that volume, and eventually from cells to the interstitial space, leaving cells dehydrated and unable to function properly. Those most at risk include young children, older adults, and chronically ill. A 5 to 10% weight loss indicates mild to moderate fluid loss, while a 15% loss is life-threatening. Third space fluid shifts can occur, which means that the fluid has had to move from the vascular space into areas like the pleural cavity, peritoneum, joints, or bowel spaces where it becomes trapped and unavailable for normal use. Causes include decreased albumin, excess IV fluids, heart or liver failure, burns, trauma, or surgery. Unlike fluid volume deficit, weight loss may not be apparent and the fluid loss is not measurable. Fluid volume excess or hypervolemia results from excessive retention of water and sodium, and this may be due to kidney dysfunction or heart failure. Excessive fluid intake occurs when sodium and water accumulate in the extracellular fluid. Fluid shifts out of cells to balance solute concentration or leaving cells, and this leaves cells depleted. The excess fluid may collect in the intravascular space, causing hypervolemia, or into the interstitial space, which would be edema. Edema is commonly seen around the eyes, the fingers, the ankles, and the sacral area, and may also affect internal organs. A weight gain of more than 5% often indicates fluid retention. Edema is typically graded based on severity, and we'll look at the slide about pitting edema on the next slide. Interstitial to plasma shifts can occur. This is a movement of fluid from the interstitial space back into the bloodstream. The body prioritizes maintaining intravascular volume, often at the expense of interstitial and intracellular compartments, because the need to have blood circulate to body organs is critical. As nurses, we need to understand these concepts about fluid shifts and imbalances. Doing accurate nursing assessments and interventions, especially in those vulnerable populations, is a part of our responsibility. This is the depiction of pitting edema. You grade pitting edema and document accordingly to paint the accurate picture, so other providers can also use this information to detect further decline or improvement in that patient's condition. So electrolyte imbalances. This occurs when there's either a deficit or an excess of key electrolytes in the body. These imbalances can signal issues with fluid balance, acid-base regulation, or dysfunction in the neuromuscular, cardiac, renal, endocrine, or skeletal system. If you think back to the information about the functions of these electrolytes. Venous blood tests are essential for identifying these imbalances, and understanding their effects is critical for accurate nursing assessment and interventions. Sodium imbalances could be hyponatremia, which is less than 135. It's called by sodium loss or water gain. Fluid shifts into cells, causing cellular swelling. Symptoms include confusion, hypotension, edema, muscle cramps, dry skin. In severe cases, may lead to seizures, coma, or death. Hypernatremia is above 145 milliequivalents per liter. It's caused by water loss or sodium excess. Fluid shifts out of cells, causing them to shrink. Symptoms include restlessness, agitation, weakness, disorientation, neurologic impairment. In infants and children, it may cause permanent brain damage. Potassium imbalances, hypokalemia is less than 3.5 milliequivalents. It's caused by vomiting, diarrhea, diuretics. Potassium shifts out of cells, affecting muscles and cardiac function. Symptoms include muscle weakness, leg cramps, fatigue, paresthesia, dysarrhythmias. Hyperkalemia is above 5 milliequivalents per liter. It's caused by renal failure or medications. It affects nerve conduction and muscle contractility. Symptoms include muscle weakness, paralysis, cardiac irregularities, and including cardiac arrest. Calcium imbalances, that's hypocalcemia, below 8.9 milligrams per deciliter. It's caused by poor intake or absorption. Symptoms include numbness, tingling, tetany, muscle cramps, and seizures. Hypercalcemia is above 10.5 milligrams per deciliter, often due to cancer or hyperparathyroidism. Symptoms include nausea, vomiting, constipation, bone pain, confusion, and slurred speech. And just note, if the levels are greater than or equal to 15 milligrams per deciliter, that's considered a medical emergency. Magnesium imbalances, hypomagnesemia is less than 1.3 milliequivalents per liter. It's caused by GI losses, alcohol use, or burns. Symptoms include muscle weakness, tremors, seizures, arrhythmias, and hyperactive reflexes. Hypermagnesium is greater than 2.1 milliequivalents per liter. It's caused by renal failure or excess intake. Symptoms include nausea, lethargy, hypoactive reflexes, respiratory depression, and cardiac arrest. Phosphate imbalances, you have hypophosphatemia, which is less than 2.5 milligrams per deciliter, caused by malnutrition, alcohol withdrawal, or metabolic conditions. Symptoms include muscle weakness, slurred speech, confusion, and seizures. Hyperphosphatemia is greater than 4.5 milligrams per deciliter. It's caused by kidney dysfunction or hypoparathyroidism. Symptoms include hyperreflexia, muscle weakness, and dysrhythmias. And then you have your chloride imbalances. That's hypochloremia below 98 milliequivalents per liter, caused by vomiting, GI drainage, or burns. Symptoms include muscle cramps, tetany, hyperactive reflexes, and in severe cases, seizures or respiratory arrest. Hyperchloremia is above 108 milliequivalents. It's caused by metabolic acidosis or kidney retention. Symptoms include tachypnea, weakness, lethargy, dysrhythmias, and coma. There's a table 41-1 in your textbook and gives a detailed overview of each of the electrolyte functions, regulation, and clinical significance. You might can make some flashcards to help you learn this information so that you'll be able to apply it. Okay, we're going to talk about acid-base imbalances. The pH represents the amount of hydrogen ions in the blood. As noted earlier, the expected reference range for the pH of the blood is between 7.35 to 7.45. When the acidity of the blood increases, the pH level decreases. When the alkalinity of the blood increases, the pH level rises. Imbalances of pH will lead to either acidosis, which is below 7.35, or alkalosis, which is above 7.45. The origin of the imbalance can be attributed in most cases to either respiratory or metabolic problem. The determination is based on clinical conditions and whether the pH level is altered due to changes in the carbon dioxide levels, or which would indicate respiratory, or if it's altered by bicarbonate levels, which would indicate a metabolic problem. Respiratory imbalances occur when changes in ventilation and reflect the amount of carbon dioxide present. Carbon dioxide combines with water and it forms carbonic acid, which makes for an acidic environment. When clients experience hypoventilation, then CO2 is retained, and then more of that CO2 is converted to carbonic acid, and you get an increase in the acidity level. Metabolic imbalances may also occur with systemic changes. The kidneys filter hydrogen and bicarbonate and either excrete them in the urine or reabsorb them back into the bloodstream. If the bicarb is excreted and hydrogen is retained, then the pH level will decrease, resulting in metabolic acidosis. In contrast, if the hydrogen is excreted and the bicarbonate is retained, then the pH level will increase, resulting in metabolic alkalosis. In most cases, the kidneys and the lungs work together and balance the acids and buffers, maintaining homeostasis. But when one or both of the systems fail, then you're going to have an acid-base imbalance, either acidosis or alkalosis. Acid-base imbalances include metabolic acidosis, which occurs when there's a deficit of bicarb, which is the base in the extracellular fluid, and this can result from either having too much acid or you've lost too much bicarbonate, such as through diarrhea or renal dysfunction. The body is going to compensate by increasing the respiratory rate and depth to exhale more of CO2, which leads to retaining more of the bicarbonate and excreting hydrogen ions in the kidneys. Metabolic acidosis is low pH, normal CO2, and low bicarbonate. Metabolic alkalosis is caused by excess bicarbonate or loss of too much hydrogen, often due to vomiting or diuretic use. The body's going to compensate by slowing the respirations to try to retain that CO2. They're going to try excreting the excess bicarb and retaining hydrogen through the kidneys. So with metabolic alkalosis, you have a high pH, a normal CO2, and a high bicarbonate. Respiratory imbalances include respiratory acidosis, which results from inadequate excretion of the CO2, usually due to hypoventilation. This is going to lead to a low pH, meaning there is acidic, an elevated blood CO2 level, which is more acid, and this is going to cause an increase in carbonic acid and normal bicarbonate. And this is going to lower the pH, making the pH more acidic. The body's going to compensate by increasing respiratory rate initially. Kidneys are going to excrete hydrogen ions and retain the bicarbonate. So in respiratory acidosis, you have a high CO2 due to alveolar hypoventilation, and you have a low pH. And you will have a normal bicarbonate. Respiratory alkalosis occurs when CO2 is excessively eliminated, typically due to hyperventilation. This is going to lead to decreased carbonic acid and elevated pH, which is more base. Compensation is going to include slowing respirations, the kidneys excreting the bicarbonate, and trying to retain the hydrogen ions. So in respiratory alkalosis, you're going to have a high pH, a normal bicarbonate, and a low serum CO2 due to alveolar hyperventilation. This is a summary slide for assessment areas for fluid electrolyte and acid-base balance, and it also has the parameters to consider. For instance, skin turgor, the findings might be decreased turgor, dry mucous membranes, and that's going to indicate fluid volume deficit. Blood pressure, you can have hypotension or hypertension. Hypotension is fluid volume deficit, and hypertension would be fluid volume excess. And then I'll let you kind of look over. I just summarized this information from your chapter. There's what you might see with findings when you have electrolyte imbalances as well. So this is a good summary slide. Okay, and this is a summary slide for the lab studies that are done and what the findings would indicate. So you have your CBC, assesses red blood cells, hemoglobin, and hematocrit levels. Your hematocrit is the percentage of red blood cells in the blood. If you have an increase in hematocrit, that means you have fluid volume deficits. If you have a decrease in your hematocrit, that means that you could have had blood loss, hemolytic reaction, or fluid overload. Hemoglobin, if it's elevated, it is a hemo concentration. If you have a decrease in hemoglobin, it could mean anemia, hemorrhage, hemolytic reactions. You have your serum electrolyte, BUN, and creatinine. Those we do evaluate electrolyte levels, and it gives you an understanding of renal function. So we have those listed there and what they can indicate with fluid deficits, dehydration, renal function, um, and such. Your urine pH and specific gravity talks about urine acidity and the concentration. Normal pH of urine is 4.6 to 8.2. A decrease in pH, remember, is acidosis. It could be metabolic acidosis, diabetic ketosis, or caused from indication of diarrhea has occurred. Increase in the pH, respiratory alkalosis, potassium depletion, chronic renal failure. Specific gravity, normal is 1.005 to 1.030. Increase in specific gravity shows dehydration. That could be from like vomiting, diarrhea, heart failure. A decrease in specific gravity could be renal damage. And then you have your ABGs, and we talked about those on the last slide. And just a little bit of a reminder, remember, for electrolytes, the kidneys are the major role here for regulating that electrolyte excretion and filtration. Okay, so this is walking through acid-base imbalance in the body and possible causes. It's a summary slide again, and we talked about a lot of these already, but respiratory acidosis, it could be due to aspiration of a foreign body, atelectasis, maybe they've had an overdose of sedatives or an anesthesia, and it's causing them to breathe not as deep or slower. They could have some chronic respiratory diseases that have inadequate ventilation, pneumonia, those kinds of things, and you would have maybe you would have your ABG showing acidosis. And treatments for that would be we want to improve their ventilation. It could be that we give them some medications. We may have to help them with getting up some of that mucus in their lungs. We want to make sure they're drinking enough so they can cough up any mucuses, and also that they're not dehydrated, and help with that filtration in of their kidneys to help with the compensation. We may give supplemental oxygen, or it could be that they end up needing mechanical ventilation. And so respiratory alkalosis, as we talked about hyperventilation being one of the causes. They may have some type of respiratory disease where they have hypoxemia. They may have high fever, sepsis. They may have a lesion in their brain that's affecting the respiratory center of their brain. And at any rate, they're having hyperventilation, increase in respirations, then we would try to get them to breathe slower. Maybe we may have to give some sedation for anxiety. We treat the underlying causes of those problems. Metabolic acidosis can be caused by diarrhea. They may have been on some parenteral nutrition, and their levels have gotten caused them to have some diarrhea or some problems with their kidneys, may also diabetic ketoacidosis, starvation. Treatment is again directed at correcting the metabolic problem. If they're having um, if they have excess in some electrolytes, we would try to eliminate the source of that issue. We would try to correct the diarrhea. We might have to give some bicarbonate to try to correct the acidosis. And then metabolic alkalosis can be caused by vomiting or gastric suction, low potassium, or being on diuretics that cause an increase in loss of potassium, or they could have some renal function problems. Treatment would be, again, reversing underlying disorder. We want to make sure that we correct any electrolyte imbalances if there's some deficit. We want to increase the excretion of the bicarbonate, and we might have to administer some IV fluids that would help restore their fluid volume. So looking at our nursing process, identifying some of the problems after we have collected assessment data, we might have some actual or some potential problems that we need to identify. And they're going to be related to fluid, electrolyte, and acid-base balance. We're going to assess the patient's status in these areas. We may uncover one or more clinical concerns, either current issues or they may be at risk for something. If the issue or the assessment findings, like diarrhea or whatnot, continue, or vomiting continue. Okay, so once we identify health problems, then we're going to be able to clearly communicate these problems to our healthcare team, the provider, and then we're going to be able to get the patient a care plan that's going to help get them back into balance, or keep them from declining further. So some of the problems that they may actually experience would be fluid overload, again, renal failure, decreased cardiac output, excessive IV fluids, excessive fluid intake, excessive sodium intake. They may say things like, I've noticed that my wedding ring is tight, indicating edema. My clothes are not fitting as well as they used to. I think I've gained some weight. They may say that they've gained 10 pounds, for instance, over the past month. They may have breast sounds that crackles. They may have an increase in their blood pressure. They may have pitting edema in their feet, lower legs, ankles. The skin might be taut or shiny. They may be reporting that they're short of breath, feeling weak and fatigued. Another problem would be fluid imbalance. It could be due to inability to either get fluids or swallow fluids, like they're debilitated, or maybe they can't tolerate them because they have oral pain. It could be due to their age. They may have vomiting, diarrhea, burns, could cause an imbalance in fluids, excessive use of laxatives, excessive sweating or fever. You'll see could see signs in changes in their mental status. They may have increased body temps, and their pulse rate goes up, and their blood pressure would go down. They may have dry oral mucosa membrane, cracked lips, furrowed tongue, or decrease in skin turgor, like signs of dehydration. They may have scanty dark urine output, and they may have a sudden weight loss. So those are all like signs of dehydration and then severe. They may also experience impaired fluid intake. This would be the inability to access fluids, or insufficient knowledge about what they need, what kind of how much fluids they need for whatever health problem they're having. Some signs and symptoms or assessment findings might be that they say, I only drink a little liquid with my meals. I don't want to have to go to the bathroom while I'm out with friends. I don't drink anything after dinner, so they're going long periods of time without drinking. They're only voiding small amounts, and the urine is going to be very concentrated, and they'll have an abnormal urine specific gravity. Their fluid intake is going to be inconsistent and less than the 1,500 milliliters per day of fluid intake. Remember, it's 2,600 overall, but the usual intake of just directly intake of fluids is about um, 8, 6 to 8, 8 ounces of fluid daily. And their skin will be dry and less supple. Okay, so expected outcomes for healthy adults. Another word for that would be your goals, what you hope the outcome for that client's health concern would be. So for healthy adult patients, expected outcomes are going to be related to fluid, electron, acid-base balance, include maintaining the approximate balance between the fluid intake and the output. Remember, it's about 2,600 total per day, and you want to check for over a 3-day period to have a more accurate picture. Another key indicator is maintaining a urine specific gravity within the normal range. And we said it was 1.005 to 1.030, which reflects that there's adequate hydration and kidney function. Additionally, patients should demonstrate self-care behaviors that promote balance, such as consuming adequate fluids and electrolytes and responding appropriately to their body, signaling them to when there is an imbalance happening. And these outcomes, they serve as benchmarks for evaluating the effectiveness of your nursing interventions and guiding ongoing care. They also help us identify any deviations from normal patterns that may require further assessment or intervention. Okay, so nursing interventions, effective management of acid-base imbalances require a combination of medical and nursing interventions to restore homeostasis. One of the primary strategies used is pharmacologic management. So these medications are tailored to address whatever the underlying cause of the imbalance. For example, I mentioned earlier that we might administer bicarbonate to correct the metabolic acidosis, and diuretics might be used to manage alkalosis by promoting excretion of excess bicarbonate or whatever other contributing electrolyte. The agents have to be carefully dosed and monitored to avoid overcorrection and any additional complications. We also talked a little bit about mechanical ventilation. It's another critical intervention, particularly in cases of respiratory acidosis or alkalosis. The patient's respiratory rate and the depth is regulated through the mechanical ventilation, which helps control the levels of carbon dioxide in the blood. And this is essential for patients who are unable to maintain adequate ventilation on their own due to a condition, maybe late-stage chronic obstructive pulmonary disease, neuromuscular disorders, or severe respiratory infections. Adjustments to the ventilator settings are made based on arterial blood gases, and the results ensure optimal oxygenation and acid-base balance. Something else we do is monitor fluid intake and output, and that's a fundamental nursing responsibility. It supports the identification and management of acid-base disturbances. We have to accurately track and help detect imbalances in fluid volumes that may contribute or result from an acid-base disorder. For example, excessive fluid loss through vomiting or diarrhea can lead to metabolic acidosis, while fluid retention may exacerbate respiratory conditions. We'll be doing dietary teaching for long-term management. Nurses educate patients on dietary choices that support acid-base balance, such as reducing sodium intake, if that's the issue. We may have to do some dietary teaching on adequate potassium and calcium levels, avoiding foods that maybe are going to exacerbate their conditions. And this intervention empowers a patient to be active in their recovery and management to prevent like reoccurrences in their imbalances. The other thing that's listed here is the selected IV fluids, and I mentioned those earlier. Isotonic, hypotonic, and hypertonic solutions, and this is just a chart that gives you a little bit more information about those. And this is just a summary of some more nursing interventions. When we take action, again, we're doing dietary modifications. It's a good summary slide. We're going to modify fluid intake based on whatever their problem is. We're going to make sure we give medications. Again, they can help with excretion or administering electrolytes that they maybe are having a deficit. IV therapy, blood and blood products may be given if they're having a low volume. TPN is total parental nutrition, so it'll if a person's unable to take in nutrition, this will include all the nutrition, including electrolytes that they need. So sometimes it's dealing with anxiety, which can exacerbate some issues, respiratory issues. And again, appropriate patient and family teaching so that they can prevent any further complications or recurrence. And I put this slide here again just so you guys can remember how to measure fluid intake and output. We did this a lot in lab. And all the ways that we did the lab where you count what is fluid intake and what is considered fluid output. And just remember that it is a more accurate picture to take this over several days to see an overall picture of their intake and output. Okay, so we're going to look at steps to reading an ABG report. It's an introduction. You are going to be looking at this to determine acid-base status and their oxygenation. You're going to be looking at, first you're going to look at the pH levels. You're going to look to see if it is between 7.35 and 7.45. Again, 7.35, below 7.35 indicates acidosis, and above 7.45 suggests alkalosis. The next thing you're going to do is you're going to look at the partial pressure of carbon dioxide, that's serum CO2 levels that we do with our ABGs, and that's going to reflect that it's the respiratory component. Normal CO2 values range from 35 to 45 milligrams of mercury. A value below 35 indicates respiratory alkalosis due to hyperventilation. Whereas if it's above 45 millimeters of mercury, it suggests respiratory acidosis, typically from hypoventilation. Then you're going to assess the bicarbonate level, representing the metabolic component. Normal bicarb is 22 to 26. If it's below 22, that indicates metabolic acidosis, and values above 26 indicate metabolic alkalosis. After you identify the pH and the levels of the CO2 or the bicarb, you're going to match them to determine the primary imbalance. For example, if you have a low pH, which is acidic, and you have a high CO2 level, that's going to indicate respiratory acidosis. If you have a high pH, alkalosis, and you have a high bicarb, that's going to suggest metabolic alkalosis. The next step is to check for compensation by looking at the total picture. So, and I'm just going to introduce this concept of compensation to you. Partial compensation occurs when your pH level is still abnormal, but the body is attempting to correct it. So, for example, you have your patient's ABGs, they show a low pH at 7.29, and that would be acidosis, and you have a low CO2, let's say 17, which normally would lead to alkalosis, right? Because if you have acidosis, for it to be respiratory, you would have to have a high CO2. This one is low, so it says alkalosis. And your bicarb is low. Normally, if you have low bicarb, that's going to be acidosis. So in this case, the bicarb is acidosis and the pH is acidosis. So that shows you that this is a metabolic problem. The decrease in the carbon dioxide level is showing that your respiratory system is trying to compensate. So metabolic acidosis with a partial respiratory compensation. The reason why it's not fully compensated is because your pH is still abnormal. So for something to be fully compensated, your pH has to return to normal, but you still might have abnormal CO2 or bicarbonate values. Okay, and the next thing we look at is, we talked about this in class, assess oxygenation status by looking at either your partial O2 levels, that's from your ABGs, or your saturated O2 levels. So the oxygenation level should be between 80 and 100, and then your oxygen saturation should be 95 to 100%. So if you had the oxygen levels below 80 or the saturation oxygen levels below 95, that would indicate hypoxemia, and you would need to provide further clinical attention because the patient is having some issues, and that would be a cause for concern. Okay, so this is a practice slide for interpreting ABGs, and then I gave you a second question over here. There's 3 examples of interpreting ABGs. Lab result, the first box, second box, and the third box. And then there's another one here that will let you drag. You can't actually drag on this slide, but you can put these in categories, whether the column on the left is either metabolic acidosis or metabolic alkalosis. And I'm going to post the answer to this probably tomorrow afternoon. So I'll give you a chance to do this on the slide, and then I will have this posted in your announcement so that you'll know what the answers of these questions are. This is a little bit of practice for ABGs. Okay, thank you for your attention to a review of the slides. We went over this all in class, but I wanted to make sure you had this to listen to it again since you had a test today and you were a little bit tired and a little distracted. And so if you have any questions, please get with me. I'll be more than happy to sit with you and explain any of these over again to you. Thank you and have a great day.